Dr. Martz, I think you're muted.
Okay, can you hear me now? Yay, okay. All right, this is going to be part one of the substance abuse lecture. So sorry for the pause there. I'm going to switch over. Okay, so let's talk about the substance abuse disorders. There are going to be 4 diagnoses here. And keep in mind that in the DSM, with the 4 diagnoses, you add whatever the substance is. So if you would add either nicotine, or you would add, say, methamphetamine, or you would add alcohol, but 4 major diagnoses according to the DSM, and then you label the substance. So the first one is substance intoxication. And so this is when you have ingested a substance and there's some kind of intoxication, some kind of effect. And they talk about development of, a lot of times it's a reversible substance specific syndrome. So if you've been drinking alcohol and you're tipsy and buzzed, that would be intoxication. But typically after enough time after ingesting alcohol, once the liver has gotten rid of it out of your system, you go back to normal. So in a lot of cases, it is a reversible syndrome. Keep in mind, it's going to be substance specific. So the effect of quaaludes is going to be different than the effect of alcohol, which is going to be different than the effect of a stimulant. And it's simply due to ingestion of the substance, however that substance is ingested. And then the psychological behavioral aspect to it is there's a significant maladaptive behavioral or psychological change. So the person feels differently, the person behaves differently, the person thinks differently due to the effects of that substance on the central nervous system. So this would be a diagnosis that would be given, let's say a person is taken to an emergency department and they are altered, and then they do blood work to try to find out what they have ingested. The people in the ER might not know, is this person always using this substance? But all they know is right here, right now, they are intoxicated. So that would be the diagnosis given to that person. The second diagnosis in the DSM is substance withdrawal. And so this would be developing, again, it's going to be substance specific. So withdrawal from a stimulant is going to look different than withdrawal from, say, a sedative is going to look different from withdrawal from alcohol, as an example. So it's the development of the substance specific syndrome, in this case, due to cessation or reduction of the substance after heavy and prolonged use. So an example would be if a person has had really heavy alcohol use, and then as they're coming down off the alcohol, get a hangover. The hangover would be a withdrawal effect, okay? And again, this is, according to the DSM, is going to create significant distress or impairment. Okay. And one way that withdrawal, I'm not recommending this, but one way that withdrawal symptoms can be eliminated is using more substance. Does that make some sense? That a lot of times people get locked in to chronic use of a substance because they can't tolerate the withdrawal syndrome, and then they keep using to end the withdrawal. Okay, it's Southern, I don't necessarily like them, but it's Southern dining for brunch. Oftentimes mimosas are offered, which is orange juice and usually some sparkling champagne or something like that. And that's because a lot of individuals like kind of the hair of the dog, if they're having a hangover from the night before, will get one of those drinks to kind of end the withdrawal syndrome. Okay, so now we're getting more into the nitty gritty here. So substance use disorder. And there's a lot we're going to break down here. This is when you get this whole maladaptive pattern of substance use. that's going to lead to a clinically significant impairment or distress. So the person can be upset about it, or the person can simply be impaired, which might be upsetting other people. And then they've got to have 2 or more of these symptoms within a 12-month period. And keep in mind, in the DSM, the way that they define these substance use disorders, it's not by how much, what kind of substance or how much people are using. The DSM bases these diagnoses on the consequences. Okay, so I want you all to absorb that. It's not the amount, it's not the substances or the amount, it's the consequences that the person suffers from. Okay, so 2 or more within a 1-year period. So recurrent substance use that results in problems filling role obligations. So problems working, problems academically in school, or problems at home with roommates or family members. There is often recurrent substance use in situations where it's physically hazardous. So this could be using and driving. This could be getting so physically impaired at a party where one could be vulnerable for a fight or could be vulnerable for unwelcome sexual contact. There tends to be craving and very strong desires to use. And then despite all of these problems, continuing to use despite the recurrent social, interpersonal problems that are exacerbated and made worse by the substance. Okay, so substance use disorder, we now have enough use that's creating impairment that is creating negative consequences for this individual. Okay. Any questions? Okay. Now we're talking about substance dependence. And keep in mind, the DSM does not use the term addiction, but this would be addiction. Okay, so what lay people use as addiction, the DSM calls it substance dependency. So it's abuse and dependency. And you're going to see this goes further than the previous. Here we've got a maladaptive pattern. It's going to lead to that clinically significant impairment or distress. But now we have 3 or more of these within a 12-month period. And the first thing they talk about is having tolerance to the substance. And physical tolerance, and keep in mind, some substances lend themselves to very powerful physical tolerance. So speed or methamphetamine would be an example of people get very quick tolerance to it. People get tolerance to alcohol, but something like using marijuana, people don't tend to get physical tolerance to marijuana, as an example, or cannabis. Okay, so tolerance is when a person needs markedly increased amounts to achieve the same level of intoxication or the same level of the desired pleasurable effect. So needing more and more and more and more to get that buzz or to get that high. The flip side of that is a diminished effect with continued use of the same amount. Okay. And I want us to think through this, because nobody starts a new day and says, hey, I would like to become an addict today. Okay. Nobody just like, I just want to become an addict today. What happens is individuals who end up dependent and addicted, they will use to get a desired effect, then they get that tolerance, and then they start using more and more often and more and more often, and working really, really hard to avoid very unpleasant withdrawal syndromes. And then people get stuck. I mean, so I have some appreciation that, you know, nobody just goes and says, hey, I want an identity as an addict. It is this thing that happens across time. Okay. Okay. Now I want to talk about opponent process. And I'm going to stop the share here for a second and let me see if I can do a whiteboard. Okay, can you all see the whiteboard? So it's just, okay, it's not a PowerPoint. I'm gonna give you an example of opponent process, and I'm gonna use something as minor as coffee, okay? Coffee is a stimulant. And I want us to think here, this is across the day. And let's say this is 7 in the morning when you wake up. And then let's say this is 2 o'clock in the afternoon. And over here, I'm going to do heart rate. Somebody tell me what coffee would do to your heart rate. Somebody yell it out.
Increase.
Thank you. Yes, it's going to increase your heart rate because coffee is a stimulant. Okay. Now, let's say about average beats per minute for heart rate for people, somewhere around 70-ish. And so I'm going to first draw for you a person's heart rate throughout the day who does not drink any coffee, does not use any substances. Now, heart rate's going to fluctuate a little bit throughout the day. That's pretty normal. But here would be sort of this normal person fluctuating heart rate throughout the day. Okay. Let's say this individual is a 3 cup of coffee drinker in the morning and a good 3 or 4 cups in the afternoon, little pick me up in the morning, little pick me up in the afternoon. This individual who is going to start consuming at 7 a.m. when they get up, their heart rate overnight is going to dip. And then they consume enough coffee after they wake up at 7 a.m. and their heart rate goes back up to normal. Same thing, they get approaching after lunch and getting close to 2 o'clock in the afternoon and their heart rate is fluctuating. And then they consume a couple of cups of coffee in the afternoon and whoa, back up to normal. Okay, what I want you to know, I'm going to stop this share here and go back to the PowerPoint. I want you all to understand opponent process because opponent process explains so many different things for us to understand substance use and particularly for us to understand addiction, okay, that dependency. And so the drug is going to create what we call the A process, whatever the effect of that intoxication for that drug is. The B process is if a person is habitually using a substance that has dependency properties, they're habitually using, this is not a one-time use, this is using over and over again. The body classically conditions the opposite process, the B process, in anticipation of the drug. So I use that coffee example, okay? And so for a non-coffee drinker, their heart rate's going to be pretty steady. For the person who drinks a lot of coffee in the morning, not just their heart rate, I want you to understand this, their entire physiology is going to move into the B process and go into the opposite direction in preparation for that drug consumption. And basically the B process, the opponent process, feels uncomfortable. It's a withdrawal kind of thing for the person who's experiencing it. Okay, so the 4 cup of coffee in the morning person, they tend to wake up and they're jonesing for their coffee. And let's say that 4 cup of coffee day person has a really rough night's sleep. And so they wake up at 7 in the morning and they're just exhausted from their poor sleep night. Then they might take 4 cups of coffee and still not feel awake because they had this really bad night's sleep. And so they might add an extra cup of coffee and now they have 5 cups of coffee and now they finally feel awake. And then now they're drinking 5 cups of coffee every morning. You got it? And then maybe drinking 6 cups of coffee. Okay, so more and more of the substance, because the opponent process, and the opponent process, we think physiologically is really kind of interesting for us. It's an attempt to keep us from poisoning ourselves to death. Okay, it's the body's classically conditioning into the opposite direction. Okay, and again, this is only if people are using over and over again. This is not a one-time drug use. Body moves in the opposite direction. And this explains a lot of things for us. So it explains that tolerance, why people start adding more and more and more. And again, people don't wake up one day and go, hey, I'd love to be addicted to substances. It's this gradual over time. It explains craving. So at 7 a.m., 2 p.m. in the afternoon, if that person's regularly consuming the coffee, that's when they are going to crave their substance. Okay. Any questions here? Okay. And again, certain substances do this more than others. So alcohol as a sedative, the opponent process for alcohol is feeling really agitated, kind of agitated and anxious. And then the consumption of the alcohol would give a little bit more of a calming effect. But I want you to note that using the substance brings the person back to normal. So again, if they want more of that pleasurable effect, they've got to use more and more and more. Okay. Also within substance dependency, we are going to have withdrawal effects. And keep in mind, the withdrawal syndrome is going to be specific to the substance. And in this situation, in this dependency situation, they keep using the same drug to either relieve or avoid withdrawal. So the person who's drinking at night and drinking during the day, they are drinking constantly to within their withdrawal syndrome and to try to maintain a feeling normal. Okay. In dependency, the substance taken in larger amounts and over a longer period of time than was intended. So we're starting to see the lack of control here. The substance is taking over control and the person's losing control. A lot of times these individuals are trying to cut down on the amount that they're using, but usually that desire and those attempts are unsuccessful. Over time, the substance use starts consuming this person's life, okay? So there's much time spent obtaining the drug, using the drug and being altered or high, or recovering from the effects of the withdrawal from the drug. So you can sort of see how the drug starts consuming their lives because the people are constantly trying to make sure they've got it. Okay. So they're pursuing it, using it, being high on it, or withdrawing from it. And the withdrawal is going to motivate more, obtain it, and use it again. Sadly, these individuals have impairment in social and relationships, occupational functioning at work. So it makes sense that a lot of individuals lose their jobs because of dependency, lose relationships, lose family because of addiction, and then also giving up what used to be recreational activities because of the drug use. And because of the physical dependency, people continue using despite knowing that they're having persistent problems and issues from the drug use. Okay. And I've spent all of my time talking about medications that lend themselves to physiological dependency. And I did use the example a little bit ago that cannabis, you tend not to have physical dependency from cannabis, but it is possible to get a diagnosis of substance dependency on cannabis because there are a lot of individuals who will get a psychological dependency on using. Okay. So it is possible to have cannabis addiction. okay? Because people will psychologically get used to the effects and will use more and more and more frequently. Questions here from anybody? Okay. Okay, let's talk a little bit about alcohol use, abuse, and dependency. So these are just kind of a serving, 4 ounces of wine, a 12-ounce beer, 1.5 ounce or shot of liquor would be 1 unit of alcohol use. When we've surveyed ASU students and asked them about consequences from alcohol use within their first year, lots of students have drank a beer, drank wine, smoked cannabis, took a legal drug that is not marijuana. We know that Greek life, so fraternities and sororities, there's this really kind of interesting increase in use for sorority and fraternity members. But I want us to think about this in 2 different directions. I want us to think critically about this. It does make sense that a lot of fraternities and sororities will focus their social events around alcohol. So having beer available, having liquor available in a party situation. And so it makes sense that if you are a part of that organization and they're your friends and you enjoy partying with those individuals, then you might personally be consuming more than you ordinarily would if you weren't a part of that organization. Okay. So everybody understands that direction. And then there's some really interesting research to suggest that in those party situations, if you do just some really simple kinds of things, you can actually decrease the amount of alcohol consumption to a safer level for individuals at that party. And that would be just simple things like having water available to drink, having food available for consumption, having the drinks in a can versus say a drink in a glass, where usually we'd have a solo cup here and not, like a real glass. And where a lot of times at a party, the drink magically, refills. Somebody helps you refill that drink. It is much harder to keep track of a open glass than it is, say, cans or bottles, as an example. So there's some things that can be done at parties to try to reduce the harm in that. Okay, so we've looked at that one direction, how being a part of one of these organizations would make it easier for the individual members to consume more. But I also want us to entertain the idea that if you've got an individual who already has substance issues or substance dependency, joining an organization like that, where let's say every night of the week, there's somebody who doesn't have a big exam the next day, somebody who will drink with you, somebody who will go out with you to a bar. It's easy for individuals with already ongoing substance issues to look normal in an organization like that. Does that make some sense? So it can kind of work in different directions, like it's readily available, but it's also more possible for a person with an addiction issue to kind of hide out and look normal in that situation. Questions there? That's my cat. He has a drinking problem. My boys dressed him up and took all kinds of pictures of him at one point in time. Okay. Consequences for college students. I don't think that any of this is going to be real surprising to any of you. Having had a hangover, 63% of college students have had a hangover at some point in time. Oops, I'll bring that back. Here we go. 50% have reported vomiting because of alcohol consumption. And vomiting is withdrawal, where your body is trying to get rid of the alcohol to protect you from getting alcohol poisoning. 40% of students regretted their actions during intoxication. 33% got in a fight, an argument or a fight. 30% missed class due to intoxication or hangover. 29% had been criticized for their drinking. And this is scary. 36% drove intoxicated. I'll give you a little bit of history about ASU. We used to be in Boone a dry county. Like you could not even get a beer at a restaurant in Boone. And then it was only within, I think like the last 10 years that we were able to get liquor and to get wine in Boone. So Boone used to be a dry county. And I think many of you all know the windy roads to Banner Elk, the windy roads to Blowing Rock, and they used to be 1-lane roads and not 2-lane roads. Students in ASU used to drive to Banner Elk and drive to Blowing Rock to drink and get drunk and then drive back to Boone. Just imagine how dangerous that was. But we were totally dry in Boone at one point in time. So there's been some interesting kind of history to that. Okay. Let me copy this. And I'm going to stop share on this and let me roll over. This is just for funsies.
Do you have feelings?
Let me this is just for fun.
Of inadequacy? Do you suffer from shyness? Do you sometimes wish you were more assertive? If you answered yes to any of these questions, ask your doctor or pharmacist about tequila. Tequila is the safe, natural way to feel better and more confident about yourself and your actions. Tequila can help ease you out of your shyness and let you tell the world that you're ready and willing to do just about anything. You'll notice the benefits of tequila almost immediately. And with a regimen of regular doses, you can overcome any obstacles that prevent you from living the life you want to live. Shyness and awkwardness will be a thing of the past, and you'll discover many talents you never knew you had. Stop hiding and start living with tequila. Tequila may not be right for everyone. Women who are pregnant or nursing should not use tequila. However, women who wouldn't mind nursing or becoming pregnant are encouraged to try it. Side effects may include dizziness, nausea, vomiting, incarceration, erotic lustfulness, loss of motor control, loss of clothing, loss of money, loss of virginity, delusions of grandeur, table dancing, headache, dehydration, dry mouth, and a desire to sing karaoke and play all-night rounds of strip poker, truth or dare, and naked twister. Warning, the consumption of alcohol may make you think you're whispering when you're not. It's a major factor in dancing like a retard. May cause you to tell your friends over and over again that you're in love with them. Also may cause you to think you can sing. Alcohol may lead you to believe that ex-lovers are really dying for you to telephone them at 4 in the morning. Alcohol may make you think you can logically converse with members of the opposite sex without spitting. It may create the illusion that you are tougher, smarter, faster, and better looking than most people. And it may lead you to think people are laughing with you. Alcohol may cause pregnancy. And it also may be a major factor in getting your ass kicked. So what are you waiting for? Stop hiding and start living with tequila.
All righty. Okay, that was just fun. Okay. Okay, let's talk about the psychological expectancy effects of this. When I was in graduate school, I wasn't in the alcohol lab, but one of my colleagues was, and one of the faculty members did a lot of research on alcohol and expectancy beliefs. This is interesting, you all. So shout out what, we just laughed at the tequila thing, but shout out some things that you expect to happen when drinking alcohol and feeling tipsy. Have y'all heard the term social lubricant? Okay, so that's sort of like disinhibited, more social, more talkative. What else? There's a really interesting effect that a lot of people expect under the influence of alcohol. People feel sexier, but alcohol impairs sexual functioning. So it's that disinhibition kind of thing of like, like they said, feeling like you can sing when you can't sing, feeling sexier or more attractive than maybe you might be, that type of thing. So people feel sexy, but the alcohol actually has the opposite effects on an individual's sexual response and sexual functioning. But we get these cultural expectations. And interestingly, in the labs that have studied this, what they do is they bring individuals into the lab and they're either paid or they get extra credit. A lot of times this research is done on men and not done on women, because when you do this research on women, you have to pregnancy test them before you give them alcohol. And they do this thing where they will either give them like a gin and tonic with lime, or a placebo where they think it's a gin and tonic, but it's really a tonic with lime. And the reason why they oftentimes make the alcohol drinks that way is that we're not very good at telling the difference between a true gin and tonic with lime and a placebo tonic and lime that they think has gin in it. So y'all understand what a placebo drink would be? People think they're getting alcohol, but they're not really getting the alcohol, but the taste is the same. So they really can't tell, okay? And what is fascinating about this research is that people actually get drunk on the placebo, okay? They loosen up, think they can sing better, think they can dance better, think they're sexier on a placebo. Now, the drinks that have the real alcohol in it, you get more of those effects. But I just want you to know that on a placebo, students, when they think they're getting alcohol, will oftentimes get tipsy and start behaving according to their expectations. Okay? This is good news for you college students. Think of how cheap, don't do parties right now because there's a pandemic, but think of how cheap a party you could have, right? Just giving people placebo drinks. There you go. Okay. Questions here about this effect? Okay. Let's talk about treatment. So individuals who truly have a substance dependency, before they can actively participate in talk therapies, often have to go through medical detox. And there's some controversy about how medical detox is handled because at times individuals are given medications, usually they're given anxiolytics, so things like Xanax, to help ease their withdrawal syndromes as they detox. So they get off the alcohol. They are oftentimes, if they're in a hospital situation, in a rehab hospital, medical doctors will prescribe something like Xanax to ease withdrawal symptoms, and then wean them off the Xanax. If they are very inebriated, they're oftentimes even given alcohol, like they call it a banana bag, will be given alcohol to help ease the withdrawal syndrome. And there's psychological controversy about that because a lot of individuals believe that you need to face and feel that really awful, gnarly withdrawal to teach that person a lesson so that they don't go back to using and drinking again, okay? The flip side of that is that there are a lot of times people can experience natural pain, and a common example is women in labor and childbirth. Yeah, there's natural pain there, but a lot of times we think the woman herself or medical professionals believe, how about we help ease her pain and let her enjoy the birth of her baby as opposed to she's so out of it trying to manage her pain, okay? So sometimes humanely, we think, but I just want you all to know there's controversy about that, okay? Many of you have heard of Alcoholics Anonymous. And it truly is, when individuals join something like this, it is meant to be anonymous. So like you go and you meet people that you know, you're not supposed to be telling other people who is in the AA group. So keeping that private and keeping it anonymous. It is a 12-step program where individuals get a sponsor. And the sponsor is normally somebody who has been sober and who has been in recovery a lot longer. So they're way down the road in their own sobriety. And then that person who's further along in their sobriety will pick up an individual who is just starting to work the AA program. And so what that does is that gives social support. Like everybody has a sponsor, they've got somebody that they can call 24/7, particularly call that person and reach out when they're craving and they want to go use or they want to go drink. And that person is supposed to kind of talk you off the ledge and help you remain sober. AA and NA, like Narcotics Anonymous, and then there's even Overeaters Anonymous, those programs are a spiritual model and they're 12 steps. So ideally, when you get into the program, you do step 1, and then you go up and you work step 2, and then you go up and you work step 3. And all along, it is meant to bring people closer to God. okay, or closer to Allah. It is meant to be a spiritual model, okay? And it is the idea that if you do not have God's love in your life, then you're missing something. And so while individuals are working on getting sober, they are oftentimes embracing that spiritual aspect. And AA, they advocate complete abstinence. And I don't have it on the PowerPoint here, but go ahead and get this in your notes. It is a medical model. It is the idea that when you have an addiction, you have a disease. And because it is a disease, you can't control yourself. And so the only way to manage the disease is to be totally abstinent from the substance. Okay? What do you all think about that? That disease idea is very meaningful to a lot of people. It is this sort of like, well, you may be able to drink in moderation and not have consequences, but because I'm an alcoholic and I have a disease, I absolutely can't touch alcohol because I get so out of control with it. So I've got to abstain. What's the flip side of that? Can somebody give me the controversy and the flip, a different way of looking at that? Have we treated other psychological disorders that way throughout the semester? If you had a phobia and you got a treatment and you no longer have a phobia, are you still a phobic? So keep in mind, an AA model, once an alcoholic, always an alcoholic. Even if you're an alcoholic who's been sober for 20 years, you're an alcoholic. What if you had a depressive episode and you got treatment and you're no longer depressed? Are you a depressive? Can you kind of see it how, at least with this treatment model, we think about psychological disorders a little differently here? But again, that's very meaningful for a lot of people in recovery. Okay. Also keep in mind that AA is not professionally run. So there's not a psychiatrist or a psychologist or a social worker running the group. The groups run themselves. Got it? Okay. The cognitive behavioral therapy, in this type of model, they think a lot about how irrational thinking leads to substance use and substance dependency. There's a lot in CBT where we're trying to replace the function. This is ethanol, stand for alcohol, replacing the function of the alcohol. Like, what is the alcohol doing for you that you could get in a different way, as an example? And a common thing would be easing tension or helping with relaxation. And again, the CBT folks might do a lot of training in meditation or self-hypnosis or progressive muscle relaxation, helping you learn how to relax without consuming the alcohol. And sometimes the goal here in this type of therapy is controlled drinking. Okay. And I want us to think about this from what is called a harm reduction approach. Okay. So get that in your notes. And again, remember, the DSM defines the substances based on consequences, not based on the use. And a harm reduction approach is a public health approach, or it can be a clinical approach one-on-one with the client, where it's how can we help you change your behavior so that you no longer have the harmful consequences. Okay. And keep in mind that a lot of people, and I'm not advocating for substance use, but I just want to be real here, and we're all adults. A lot of people will drink and enjoy it and have no harm, will smoke cannabis and enjoy it and have no harm. Some people even do the hard stuff like cocaine and have no harm, but it's challenging to use some of those kinds of things and not get hooked on it. I have been exposed to cocaine in my life, but I have never, ever tried it, because from the description of it, I think I really like it. I think Denise Marks would really like it. So I've just like, whenever I've been exposed to it, it's like, oh, no, thank you. You know, it's just psychologically, it sounds dangerous to me. Okay. So a lot of people use without any harm. So sometimes the goal is to help the person. A lot of times they have to go through sobriety, total sobriety first, and then reintroduce very gently the substance and really help that person work on moderation. Some of the rehab centers, this is going to surprise you all, some of the rehab centers will actually have a bar, a mock bar inside the rehab program, where at the end of the rehab program, people practice in their therapy going to the bar, ordering a drink, enjoying that drink, and then stopping. Maybe continuing to socialize and drink soda or something like that, or drink water, but there's no harm in having one drink and stopping. Okay, so some of the treatment programs will, again, a lot of times for people, particularly if they've got dependency, will advocate for, in treatment, total sobriety for a while, but then reintroducing if individuals desire to do that harm reduction approach and want to be able to go to a wedding and have champagne, go to a bar with their friends and have a glass of wine, but learn how to drink and stop. Does that make some sense? Because that's kind of what a lot of people do who have no harm in their behavior. There is a tremendous amount of controversy about that, because the AA people would say that is the wrong way to do treatment. And these people down here who have been successful in this say sometimes AA is too rigid with that disease model. Okay. The AA people would counter and say, you're fooling yourself if you think you want treatment for controlled drinking, because a lot of people who aim for controlled drinking, less harm, end up abusing and becoming dependent again. Okay. So I just want you to recognize that these two treatment approaches, and some people go into treatment and do both. Some people get a professional therapist, or they go to a professional rehab program, and then they're doing AA in the rehab program also, or after they get done with their professional treatment, they're still going to AA groups. So some people do both of these things, but I want you to know they're a bit at odds with one another. Okay. So the question that, well, let's talk a little bit about motivational interviewing or motivational enhancement therapy. I want you to know this is also called motivational interviewing. This is a therapeutic approach. Like, I've been trained in MI, and I use this quite frequently with my clients. I also sometimes use it with my loved ones, because it's a great way of having sensitive conversations with family members. And it's a really humanistic way of interviewing and offering feedback to very gently nudge people into change. And motivational enhancement therapy is the absolute opposite of confrontation. Okay. There are a lot of those TV shows where they do these interventions, and they show these confrontations where all the family and all the friends get together and like, you're an alcoholic, you need to go into rehab. Motivational interviewing is the opposite of that. It would be, say, sitting down with an individual and saying, I'm hearing your family members say that they're worried about your drinking. Would it be okay if we spend a little bit of time talking about your alcohol use? And the person's kind of, even if the person's kind of reluctant or ambivalent, they usually, if you ask nicely, people say yes. Yeah, it would be okay. Well, tell me your perspective on your drinking and what that does for you. And then they might say what it does for them. It's like, okay, from your perspective, do you feel like there are any problems that spin out because of your drinking? So it's very gentle, and we offer a lot of empathy, and we offer a lot of understanding, and the therapist gets down on the level of the client or the patient. And it is just a really nice way of assuming everybody tends to have some ambivalence. So even a drinker who is committed, I want to keep drinking because I just really love it, is going to have some ambivalence. Like, yeah, you know, I did fall when I was drunk that time, or I do tend to pick fights with my significant other when I've been drinking, or yeah, I do worry about my kids seeing me when I'm drunk. So they take that ambivalence and you really work with it in motivational interviewing. And so I guess the question here becomes, which one works better? And I'm going to end with this today. We'll finish up this lecture. This Project Match, when I was down at the Medical University of South Carolina, they were a site for Project Match. I had nothing to do with it, but they were there were a bunch of different med schools that had clinical trials running on this. And there were two arms. There was an outpatient that they were studying. They were studying outpatient treatment, and they were also studying individuals who had been inpatient in a rehab program and then were discharged to outpatient. So outpatient only, and those who'd been in rehab and then discharged. And they randomly assigned a bunch of these individuals that had alcohol addiction. And they, in their random assignment, I want you to pay attention to that. They did not select which program they got, what kind of treatment they got. They were just assigned to it randomly. A third got AA, a third got cognitive behavioral therapy, and a third got motivational enhancement therapy or motivational interviewing. And it was very surprising, again, because remember the AA and the CBT people are sometimes at odds and they think, no, we're better, no, I'm better, no, I'm better. The results, there was virtually no difference in treatment outcome. And so what this told a lot of professionals is that treatment is effective. You know, you can go get whatever treatment that seems like it fits your ideals. Treatment can be effective, and we don't see major differences in these. And again, a lot of people, when they're recovering from addiction, will get both professional help and join AA and join NA. Questions here? Anybody? Okay. I'm going to go ahead and stop share. And does anybody have any questions before we finish up today? Okay, same kind of thing. I'll be rolling into my office hours here in a little bit. Good to see everybody. Y'all take care. Bye.